The future outlook for stage 4 is quite likely to search in a more appropriate way for predictive biomarkers, because PD-L1 is a sort of enrichment factor, is not a clear-cut predictive biomarker. So we know that if we have an extremely high expressors, a tumor that is expressing a high level of PD-L1, the likelihood to get a therapeutic response and to get a prolongation of the PFS is higher. In addition to that, I believe that the future will lead us to explore the combination of not only of immunotherapy and chemotherapy, but different immunotherapeutic agents, not necessarily CTLA-4 inhibitors and immunocheckpoints inhibitors, but there are also other new drugs coming to the stage that need to be investigated in a proper way. But what is much more important from my point of view is to consider immunotherapy in the context of a precision medicine approach. Because if you go back to the past saying or informing physicians that this is a type of treatment for everyone, we are not doing our job. As we did for targeted therapies, also for immunotherapy, we need to bring this new treatment opportunity in the context of a precision medicine approach, as well as we need to increase the amount of molecular tumor boards that we have in our hospitals. Moving ahead and looking to the early stages, this is another interesting area. There are different converging lines of evidence that we can do early detection of lung cancer through screening methods, and I'm alluding in principle primarily to the recent data that has been published on early detection through low-dose CT scan. We have now 2 positive studies. I would like to bring in the discussion the idea that probably we are not completely ready to offer the screening to everyone that is a current smoker or former smoker. We need again to select in the most appropriate way the potential candidates for screening studies. But what we know through the screening studies, we can increase the proportion of patients who are diagnosed in early stages. Having a significant improvement in stage 4 non-small cell lung cancer, having new treatment opportunities, we need to move these new and effective treatment opportunities in the field of early stages. That means that probably we need to consider adjuvant studies, but to get the results of adjuvant studies, it takes a long time, while for the neoadjuvant studies, you can deliver this type of treatments in the pre-surgical setting. You have the baseline biopsy, you can do molecular biology on the baseline biopsy. You have in 96–97% of the cases the resected tumors. That is what the feasibility studies told us. And you can do molecular analysis, you can do correlative studies on resected tumors. And in such a way you can improve quickly your knowledge in terms of the molecular biology of cancer.